Hi, my name is Erin Alaia, and today I'm just going to give a brief overview on a basic approach to musculoskeletal radiographs. And today I'm going to be talking about musculoskeletal trauma that you're commonly going to be seeing when you rotate through eye care. So I'm going to focus on each anatomic region. I'm going to show you examples of common traumatic pathology that we see every day. So first, looking at the shoulder. Here we have normal externally rotated and transscapular Y radiographs of the shoulder. So I know this is an externally rotated radiograph because I'm seeing the greater tuberosity of the humerus in profile. So I'm looking for any fracture or cortical offset. I'm looking at alignment of both the glenohumeral and acromioclavicular joint. The acromioclavicular joint looks good on this frontal view. It's symmetrically aligned. The glenohumeral joint I'm able to evaluate on the transscapular Y view. I can see here that the humeral head is centered over the glenoid. And for reference, here we have the coracoid. That is your marker for the anterior translation, and the acromion, which sits posteriorly. So this is a nice normal radiograph of the shoulder. So here we see an example of a comminuted proximal humeral fracture. So when I'm evaluating a fracture of the proximal humerus, I'm looking at what parts of the proximal humerus the fracture involves. Commonly here you see involvement of the greater tuberosity. Often there's involvement of the lesser tuberosity, the surgical neck, or the anatomic neck. And here we're seeing valgus impaction along the surgical neck, or the distal shaft is pointed away from midline, and I'm seeing displacement of the greater tuberosity fracture fragment. Now, importantly, in the proximal humeral fractures, I'm always going to be mindful also of glenohumeral alignment. And I see here on the transscapular Y view that the humeral head is nicely centered over the glenoid. So this is a comminuted proximal humeral fracture. This is the axillary view. So here we see an axillary view of the shoulder. Anterior, again, your reference is the coracoid bone, which is here. Posterior, we have the acromion, and normally the humeral head should be nice and centered over the glenoid, but we see that it's actually anteriorly translated. This is an anterior glenohumeral dislocation. So the humeral head is going to impact the anterior inferior glenoid. So you can see a fracture along the anterior inferior glenoid, which is known as a bony Bankart fracture, and an impaction fracture along the superior posterolateral humeral head that's known as a Hill-Sachs lesion. And this is a nice example of a Hill-Sachs lesion. This is an internally rotated view showing us the superior posterolateral humeral head. And you're seeing this concave impaction deformity. So this is a classic appearance of a Hill-Sachs lesion associated with anterior glenohumeral dislocation. So this is a really important radiograph because it's commonly missed. And I just want you to remember this and to show you this. Never order a single frontal view of anyone. Often I will see, pregnant patient, frontal view of the wrist, rule out fracture. You need more than one view to evaluate for fracture and to evaluate alignment. So if you quickly, looked at this radiograph, you might say it's okay. But what I notice is that the proximal humerus it's internally rotated. So that's your first clue. You never want to pass a shoulder radiograph that is only showing you an internally rotated view. When we look at additional views, here we see the transscapular Y view. Instead of the humeral head being centered upon the glenoid, it's posteriorly translated. So we know this is posterior because we see our posterior reference here being the acromion. And our axillary view is really giving us the full story. This is a posterior shoulder dislocation. The humeral head is perched upon the posterior glenoid. Here we have a reverse Hill-Sachs fracture. You can also have a reverse Bankart fracture. This is the classic appearance of posterior glenohumeral dislocation. So again, never forget that frontal view, locked in internal rotation. You never want to just rely on a single frontal view to evaluate for alignment. Here we have internally and externally rotated views. Here's the externally rotated view. Again, I'm seeing the humeral greater tuberosity. Here we have the internally rotated view when I'm seeing the greater tuberosity on FOSS. And here on the externally rotated view, we're seeing a hairline non-displaced humeral greater tuberosity fracture. So sometimes the hairline non-displaced fractures, you're not going to see actual cortical offset, but here we're just seeing this lucency. And the humeral greater tuberosity is one of the locations where non-displaced fractures can be very subtle, and sometimes we only see them on MRI. This was actually missed in the ER, and it's a nice example of how subtle greater tuberosity fractures can be. This is really an important radiograph and a reminder that you need to look at the entire image. So I talked about alignment of the glenohumeral acromioclavicular joint, and I think you will all see here that there is malalignment of the acromioclavicular joint. This is a grade 3 acromioclavicular joint separation injury. You see superior translation of the distal clavicle, widening of the acromioclavicular interval. It shouldn't measure more than 8 millimeters. There's also widening of the corticoclavicular interval. It should not measure more than 13 millimeters. So this is a grade 3 injury, but we're not done. This patient has even more. So if you look down here at the ribs, now I evaluate the ribs by carefully, with my eyes. It takes a long time and it's kind of painful, but I'm looking along each of the cortices of the ribs. And just for the purpose of time, here you'll see subtle angulation here and cortical offset. This is a rib fracture. But, whenever you see a rib fracture on a film, you also want to evaluate for pneumothorax. So importantly, this patient also has a right-sided small to moderate pneumothorax. And here you're seeing the collapsed lung here. This subtle line here is representing the collapsed lung. So this is a right-sided pneumothorax in the setting of rib fracture. And we also have a grade 3 acromioclavicular separation injury. You may also see this come through eye care. These patients often will present with acute pain. So this is an axillary view of the shoulder. And here along the lesser tuberosity, we're seeing this globular calcification. So this is a characteristic appearance of calcific tendinosis. Here it's deposited at the subscapularis attachment. When the deposit has vascular invasion, it starts to liquefy and enlarges, and then it will subsequently rupture into the overlying bursa. This can be intensely painful for the patient, and they will often present to the ER. This is just a classic nice case of calcific tendinosis. So moving on to the elbow. So when I'm looking at the elbow, again, I'm always looking for a fracture in the adult patient. The most common location is going to be the radial head, looking to see whether or not it extends to the articular surface. Sometimes radial neck fractures, you're just going to see a very subtle cortical offset on the lateral view. Importantly, you always want to evaluate radiocapitellar and ulnohumeral alignment. The radial head should always be aligned with the capitellum on every view. And you also want to do a QA check. You want to make sure that it's a good lateral view. I'm seeing both the olecranon and the coronoid fossa here. I'm seeing the cortices along each fossa in profile. I'm seeing the cortex of both the capitellum and the trochlea. This is a perfectly aligned lateral view. And I'm also going to be looking for an elbow joint effusion. So they are normally fat pads that are tucked into the coronoid and olecranon fossa. They become lifted when you have a joint effusion, and sometimes, the radial head fracture will be radiographically occult, and the only thing we'll see is a joint effusion. I'll be showing you that in the next few slides. So often, if I don't see a radial head fracture, but I see the effusion, we'll recommend follow-up radiographs after 7 to 10 days. So again, you're looking for fractures, you're looking for malalignment, and we can see this obvious malalignment of the elbow here. The olecranon and the radius have been posteriorly and laterally dislocated. You can see here the olecranon is completely uncovered. In posterior dislocations, you'll often have this shear fracture of the coronoid process. You can also see fractures of the radial head and impacture fractures along the posterior margin of the capitellum. So very similar to what we see in the shoulder with Hill-Sachs fractures and bony Bankart fractures. So here's that example. We have frontal and lateral views of the elbow. I see a large elbow joint effusion. So those fat pads have been lifted. This is called the Sale sign, an indicator of a joint effusion. And the adult patient, you want to have high suspicion for there to be an underlying fracture. It's almost always going to be of the radial head. And that's exactly what we're seeing here. I'm seeing here on this oblique view an intra-articular radial head fracture. I'm looking for any gapping or depression along the articular surface. This is something else we very commonly see. Again, this patient has a large joint effusion, and they also have this intra-articular fracture of the olecranon. The problem with olecranon fractures, the fracture fragment is going to be pulled by the triceps, so it's always going to be under tension. These will almost always go on to surgery. We can see here the fracture fragment has been proximally distracted by the triceps tendon. This is something else we occasionally will see in the ER. You want to look at your bones, but you also want to look at the regional soft tissues. So this patient has this spur here. This is called an enthesophyte. Any place where you have an inserting tendon, over time you can get tug that causes this bony spur or an enthesophyte to form over time. But we are also seeing this focal soft tissue swelling overlying the olecranon. There's actually a bursa that lives here. It's called the Olecranon bursa. When you see this focal soft tissue swelling, this is Olecranon bursitis. It can happen in inflammatory conditions, rheumatoid arthritis. We see this in gout, sometimes in trauma. Occasionally, you can have septic Olecranon bursitis. When you're looking at radiographs of the forearm, you want to look for fractures, but you always want to look at alignment of the elbow and the distal radial ulnar joint, okay? So here we are seeing a fracture of the shaft of the ulna, and we're seeing malalignment at the radiocapitellar joint. So this is the Monteggia fracture dislocation pattern. Again, you want to look for the fracture, but you also, for the forearm, always want to look at the elbow and the distal radial ulnar joint so that you can identify these fracture dislocation patterns of injury. And here's the accompanying injury. Here we're seeing a displaced fracture of the mid to distal radial shaft. And now we're seeing dislocation at the distal radial ulnar joint. We're seeing marked widening of the distal radial ulnar joint and positive, post-traumatic positive ulnar variance. The ulna is also dorsally translated. So this is the Galeazzi fracture dislocation pattern of injury. Moving on to the hand and wrist. So hand and wrist, in the wrist, I'm looking at the arcs of carpal bones. You should see them nice, smooth lines. You should see all of the joint spaces. You don't want to see any abnormal overlap. Importantly, on the wrist, on the lateral view, I want to see the distal radius, which is right here, the lunate bone, and the capitate. I want to see them all perfectly aligned. You want to similarly look at alignment of all the digits. Sometimes you'll see, volar plate avulsion fractures, tendinous avulsions only on the lateral view. And if you have suspicion for injury to a specific digit, you want to get the coned in smaller views of the dedicated digit. So this is bread and butter orthopedic trauma. Here we're seeing a comminuted intra-articular distal radial fracture. So when I'm looking for distal radial fractures, I'm looking as to whether or not they're intra-articular to the extent of the distal radial ulnar joint, the scaphoid facet, the lunate facet. This is definitely intra-articular. It's impacted, and that impaction has resulted in loss of the normal radial inclination or the slope between the lunate facet and the radial styloid that we normally see. Impaction has also resulted in post-traumatic positive ulnar variance. The ulna is more distally located. It should be at the same level as the radius, and that ulna can impact upon the lunate and the triquetrum. Normally you have mild volar tilt of the articular surface, but here we see that there's dorsal articular surface tilt. So this is a fracture that will definitely need to be reduced. And here we're also seeing the accompanying, we often will see an ulnar styloid avulsion fracture. You also want to evaluate in distal radial fractures alignment of the carpal bones, and here they look good. So you're seeing the distal radial articular surface aligned with the lunate, aligned with the capitate. This is another fracture that we commonly see, and occasionally these can be radiographically occult. Please, if you have any suspicion for a scaphoid waist fracture, order the dedicated scaphoid view. The hand is in ulnar deviation, producing tension upon the scaphoid, and this will reveal an otherwise radiographically occult scaphoid waist fracture. So this is a nice example of why it's so important on the lateral view to look at alignment. So on the frontal view, I'm seeing this abnormal pie-shaped appearance of the lunate bone. This is the first thing that is cluing me in to there being a more advanced injury pattern. So on the lateral view, here we have the distal radius, the lunate bone, and the capitate should cover the lunate bone, but we see that the capitate is translated dorsally while the lunate bone is translated volar. And you can see here there's volar tilt of the lunate. So this is a midcarpal dislocation pattern. So the normal appearance of the wrist in the lateral view, distal radius aligns with the lunate, aligns with the capitate, also aligning with the third metacarpal. In a perilunate dislocation, the lunate is normally aligned with the radius, but the capitate is dorsally translated. In a midcarpal dislocation, both the capitate is dorsally translated with regard to the radius, and the lunate is volar translated with regard to the radius. And that's what we just saw. And the most advanced pattern of injury is when the capitate is normally aligned with regard to the radius, but the lunate is dislocated volar, and that's a lunate dislocation. Here's a nice example. As I said, if you know that one finger has been injured, the dedicated finger radiographs are very useful and important to order. So here we're seeing a lateral radiograph of the fifth digit. It's subtle, but you can see here the distal interphalangeal joint is in subtle flexion, and that's because here we actually have an avulsion fracture of the terminal extensor tendon's attachment onto the distal phalanx. It's a distal extensor tendon avulsion. This is known as the mallet finger. And as a result of injury to that extensor tendon, you have this mild flexion of the distal interphalangeal joint. This is a mallet finger. And this is really an important radiograph. Again, as I said, you want to look at all the joint spaces. You want to make sure there's not abnormal overlap. Here, and this can be missed, you're seeing this abnormal overlap between the base of the fifth metacarpal and the hamate. So normally, the base of the fifth metacarpal should be completely covered by the hamate along the articular surface. And here you can see uncovering an abnormal overlap between the fifth metacarpal base and the hamate. So this is actually a fifth carpal metacarpal dislocation. You can see here the lateral view for the carpal metacarpal joints can be nearly useless. We're not seeing anything on the lateral view. So it's important to always take a look at the carpal metacarpal joints. Moving on to the pelvis and hip. So when I'm looking at the pelvis and hip, so I'm looking at the lines. I'm looking at the iliopectineal line, the ilioischial line. I'm looking for any cortical offset that would be indicative of an acetabular fracture. I'm obviously looking for any cortical disruption along the intertrochanteric region, the subcapital femur, the femoral neck. You know, something else specifically for the femoral neck and the subcapital femur, I'm looking at the trabeculae, and I want to make sure they're intact and I don't see any impaction. This can be your only clue sometimes to a subcapital fracture, which can be occasionally subtle. I'm also looking at all the cortices along the sacral ala. Sometimes you can pick up on a sacral alar fracture. And I'm also looking at width and alignment of both the symphysis pubis and the sacroiliac joints. You want to be clued into any asymmetric widening of the sacroiliac joint, malalignment of the symphysis pubis. You can occasionally see in complex pelvic fractures. This is a common fracture that we see. So here we have a comminuted fracture of the intertrochanteric femur. This is a varus impacted fracture. So the distal shaft is pointed more toward the midline. So this is a varus impacted intertrochanteric femoral fracture. Here we see a nice example of why the trabeculae becomes so important. I think you can understand here that the angulation between this femur and the left and the right femur is a bit different. This on the right, where it looks a bit impacted. The patient is externally rotated. The greater trochanter is overlapping with the femoral neck. But if I look carefully, these trabeculae here in the subcapital region are actually disrupted, unlike the left side. So this is actually a valgus impacted subcapital right femoral fracture. And occasionally these can be subtle and they are occasionally missed. So it's important, again, to take a close look at the trabeculae, order a CT if there is high clinical suspicion. Here is, again, another example of a fracture that we commonly see. And this highlights why it's so important to follow the iliopectineal and the ilioischial lines. Here on the left side, we see intact normal iliopectineal and ilioischial lines, but on the right side here, we're seeing that they're disrupted. So this is a comminuted acetabular fracture on the right. This is a very subtle case, but something that we do occasionally see. So if you look carefully at the femoral neck, so we have the compression side of the femoral neck and the tension side. Compression side inframedial, tension side is superolateral, and we see this subtle fuzzy sclerotic line along the compression side of the femoral neck. This is a compression-sided femoral neck stress fracture, and a lot of times we're only going to be seeing these fractures when we have micro callus deposition or healing change. Again, if there's high suspicion, you want to order the MRI. This one's a little bit more apparent. Here we're seeing an actual break in the tension-sided femoral neck cortex. So these are at much higher risk of progressing. The tension-sided femoral neck stress fractures will go into surgery. So this, again, tension-sided femoral neck stress fracture. Here we're seeing a fracture of the proximal femoral shaft, but it's more than this. A lot of times you'll see these in elderly females that are on a certain medication. This is an atypical or bisphosphonate femoral fracture. You know, I can identify this based on the location within the proximal femur. And importantly, you're seeing at the area of fracture this focal cortical thickening. So this is a stress reaction that we see prior to the completed fracture. And this is our indicator that this is a bisphosphonate fracture. Importantly, you always want to look at the contralateral femur. And I often will see this missed in the proximal femoral shaft. It's always laterally. You want to look for this area of focal cortical thickening. Occasionally, you'll see a transversely oriented fracture line. A lot of times, these patients will get MRIs to further evaluate for any underlying fracture. So these are the bisphosphonate or atypical femoral fractures, and here we're seeing stress reaction on the other side. Moving on to the knee and lower leg, here are normal radiographs of the knee, frontal, lateral, and sunrise views. For the trauma films, the fractures that are going to be subtle are really the tibial plateau fractures. So I'm tracing my eyes along the tibial plateau. Importantly, the medial plateau has a more concave appearance. That's how you can identify it on the lateral view. I want to make sure I don't see any depression or offset of that surface. The other fracture you're going to see, and it's going to be more apparent, is going to be the patellar fracture. You want to look for a joint effusion or distension, thickening of this suprapatellar recess if it measures more than 10 millimeters as an indicator of underlying fracture or, cartilaginous, meniscal, or ligamentous injury, internal derangement. So this is a nice example of a very subtle fracture. So if you carefully, trace along the lateral tibial plateau, you're going to see this subtle cortical offset, and we can appreciate depression here on the lateral view. So this isn't a lateral tibial plateau fracture. If it's not called and there's high clinical suspicion, you want to get the CT. It's going to be much more apparent on CT. So these tibial plateau fractures can be very subtle. And I initially was talking about the humeral greater tuberosity. The tibial plateau is another area where I know fractures can be super subtle. I closely scrutinize the tibial plateaus, and if I have any concern, I have low threshold for recommending a CT. This is an obvious example of a transversely oriented patellar fracture. This is under tons of tension. It's being pulled apart by both the quadriceps and the patellar tendons. These go on to surgery. In contrast, this is the stellate fracture of the patella. Stellate, Latin for star, and multidirectional comminuted fracture of the patella. It's non-displaced. These usually heal not operatively. Here you're seeing this low signal fracture line. The patellar fractures can be subtle on the frontal view, but I think you can appreciate this multi-directional stellate fracture. Something else that we occasionally see in the ER, to the uninformed reader, this could look like a relatively benign fracture, but it's actually an indicator of a much more advanced injury. This is a Segond fracture. So this is an avulsion here of the soft tissues. It's just posterior to the iliotibial band, the anterolateral capsule. Segond fractures are always, everyone who has a Segond fracture pretty much has an ACL tear. Not everyone with an ACL tear has a Segond fracture. The point is, when you see the Segond fracture, order the MRI to evaluate the ACL. Here on this lateral view of the knee, this is an example of a proximal tibial stress fracture. So I'm seeing this transversely oriented lucency along the anterior cortex of the proximal tibial metaphysis. I do see some adjacent cortical thickening. This is a classic appearance of a tibial stress fracture. It's important to, again, not only look at the bones, but look at the regional soft tissues. Here you can see a lot of soft tissue swelling in the infrapatellar region. You can see here that the patella has been pulled proximally. This is patella alta. The MRI is going to be so much more helpful to tell you the full story of what's going on in the soft tissues. And here we're seeing a complete rupture of the proximal patellar tendon and post-traumatic patella alta. Moving on to the ankle and foot. So the ankle, I'm looking at the ankle mortise. I want to make sure it's congruent, looking for any abnormal widening of the medial mortise, which would be indicative of deltoid ligament injury. I'm looking at the syndesmotic clear space, which is right here, the amount of tibiofibular overlap. If you see this is abnormally widened, you think of syndesmotic ligament injury. I'm looking obviously at all the osseous structures in the foot. Importantly, you always want to look at the Lisfranc alignment. I'm looking for any abnormal widening between the base of the first and second metatarsals, offset at the second tarsometatarsal joint, both on the frontal and lateral view. This is a nice example of something we commonly see, a trimouth fracture. So I see a mildly displaced medial malleolar fracture, a fracture of the distal fibula, and I'm also seeing, you always want to look on the lateral view for the occasionally subtle posterior malleolar fracture. Here's a nice example on the stress view of the ankle. I'm not seeing a fracture, but I'm seeing abnormal widening of the syndesmotic clear space. When you see this, you always want to look north for the proximal fibular fracture, the Mason-Neuve fracture. Here on lateral and axial views, we are seeing a comminuted fracture of the calcaneus. So normally the calcaneus should form this angle known as Bowler's angle, but when you have a calcaneal fracture, commonly it will traverse the posterior subtalar joint. You're going to get joint depression. You're going to get loss of that normal Bowler's angle. You always want to look for and evaluate for extension to the posterior subtalar joint, any depression along the articular surface. This is a calcaneal fracture. Another fracture we commonly see here is a fracture along the base of the fifth metatarsal. This is an avulsion type fracture at the peroneus brevis attachment, and it's extending into the tarsometatarsal joint. It's important here at the fifth metatarsal base, those peroneus brevis avulsions will be in zone 1 here, whereas the Jones fracture, the metadiaphyseal junction, or watershed avascular zone, is going to be right where the bases of the fourth and fifth metatarsals overlap. This, again, the watershed zone. Occasionally these fractures will not heal. There'll be more delayed healing due to the tenuous blood supply. This is distinguished from the more distal proximal diaphyseal stress fracture. So here's a nice example of a peroneus brevis avulsion fracture. Here in the middle, we see the typical Jones fracture at the metadiaphyseal junction. And on the right, we're seeing a proximal diaphyseal fifth metatarsal stress fracture. It's important in the pediatric population to remember that there's a normal longitudinally oriented apophysis along the fifth metatarsal base that is normal and should be differentiated from the transversely oriented fifth metatarsal base fracture, which we're seeing here. So this patient has both. As I said, it's important to always look at alignment of the Lisfranc joint. So here it's obvious that the Lisfranc joint is fractured and dislocated. All the metatarsals here are laterally dislocated. You can see uncovering of the medial and middle cuneiforms. You want to order a CT to evaluate for associated fracture of the cuneiforms and the metatarsal bases. The lateral view, again, you always want to look at tarsometatarsal alignment. Here I can see malalignment of the first and second metatarsal joints. I'm going to show you a bunch of examples of Lisfranc injury because it's so important to not miss. Here, it's a more subtle example, frontal and lateral views of the foot. You're seeing this abnormal widening between the bases of the first and second metatarsals, offset at the second tarsometatarsal joint here. This should be perfectly aligned along their medial cortices. So this is a definite Lisfranc ligamentous injury. You can also look on the lateral view. Again, this is the second tarsometatarsal joint. We're seeing subtle malalignment here. You can see that the middle cuneiform is more plantar, translated with regard to the second metatarsal base. So this is another example of Lisfranc dislocation injury. Occasionally, you'll see this flexi where the ligament attaches at either the medial cuneiform or the second metatarsal base. Here, this patient has had Lisfranc ORIF. And again, one last example. Again, here we're seeing, again, that abnormal widening between the first and second metatarsal bases, offset of the second tarsometatarsal joint. And here on MRI, we're seeing complete absence of the Lisfranc ligament that normally extends between the medial cuneiform here and the base of the second metatarsal. The last case I'm going to show you here on the lateral view, it's very subtle, but we're seeing this fuzzy sclerotic line along the calcaneal tuberosity. It's at a right angle to the trabeculae that normally run through the tuberosity. This is a healing calcaneal stress fracture. Again, a lot of the stress fractures we're not going to see unless they're healing, and we see callus deposition. If you have high suspicion for stress fracture, order an MRI. So thank you very much for your attention. I gave you a broad overview of some of the trauma that you're going to be seeing in eye care. Please do not hesitate to reach out to any of the musculoskeletal radiologists in the reading room or when we're on call. Please email me if you have any specific questions, and we look forward to working with you. Thanks a lot.